I'd like to talk about Crohn's disease and ulcerative colitis because they often get mixed up. They are both probably an autoimmune disease, and that is somewhat controversial because there seems to be an elevation in antibodies, and that's about all that we got on to suggest that they could be autoimmune diseases. That means we're going to have a rouleau effect, and the sed rate would increase in both of them, and that's indicative of some kind of infection or inflammation process, right? There's also an elevation in the T and B cell response. The T and B cell numbers increase. That's a hint that it may be autoimmune, or it may be a response to something in the environment, but nobody has pinned it down yet, at least not that I've seen. They both have a pattern of familial occurrence, and both can be accompanied by systemic manifestations. Crohn's disease most commonly affects the distal small intestine and proximal colon, but can affect any area of the GI from the esophagus to the anus, whereas ulcerative colitis is confined to the colon and rectum. The sigmoidoscopy or the colonoscopy can show the cobblestone effect that we typically see in Crohn's disease, and this cobblestone effect results from the fissures and crevices that develop surrounded by areas of submucosal edema. It also has, quote, skip lesions because they are interspersed between what appears as normal segments of the bowel. And up here in the top right picture labeled A and B, I'm showing you the common areas where Crohn's disease affects the small intestine and large intestine versus ulcerative colitis, which affects the descending colon, sigmoid, and rectum. Below that, you're seeing a photograph of an intestine from a patient with Crohn's disease, and you can see the cobblestone effect. The bottom picture, bottom right, is showing you ulcerative colitis. The major attack in the colitis condition are the crypts of Lieberkühn, or intestinal crypts. Again, Crohn's is more through the GI tract. Crohn's is more widely spread, but also ulcerative colitis conditions affects the crypts of Lieberkühn in the rectum and colon. Now in the bottom left picture, the cartoon, this is a villus, and you have your cells that make up the villi, the simple columnar cells, and then right next to it is a crypt of Lieberkühn. And what do they do next to the villi? The crypts contain granule-rich Paneth cells. That's the inset part of that little cartoon picture. These cells discharge their granules into the crypt lumen in response to entry of bacteria or food-related stimulation by acetylcholine. The highest concentration of antimicrobial defenses from the Paneth cells are reached in the crypt, from which the intestinal stem cells continually regenerate the absorptive epithelium of the villi. In other words, these crypts of Lieberkühn are not only important in releasing antimicrobial defenses, but they also replenish the simple columnar epithelial tissue. The shedding of the senescent epithelial cells from the tips of the villi is shown in this picture. The colitis condition will attack those particular crypts and enlarge them. So you see that kind of patterning in the rectum and colon with these inflammatory lesions that often extend into the lumen, and they resemble polyps and are therefore called pseudopolyps. And the bowel wall thickens in response. You often hear people mixing up diverticulosis with diverticulitis. There is a big difference. Diverticulosis are little outpocketings, primarily along the colon. It's really the mucosal layer of the colon herniating through the muscularis layer. And diverticulitis is an inflammation of the diverticulum. And they can be multiple or they can be singular. You can see them with a sigmoidoscopy or a colonoscopy. You can see the presence of diverticula here in this picture. Development of diverticula is thought to be a genetic predisposition. By themselves, they are not harmful. If they enlarge, they can serve as little diverticulous sacs, similar to the ones that I showed you or told you about in the esophagus. You get those little outbulgings of the esophagus, which I said was the diverticula. But in the intestine, these diverticula normally do not cause a problem unless they become infected. And the problem with the infection is you get E. coli, and E. coli are famous for this. They wind up in the little blind sac, and then what happens is it becomes inflamed, and these things become quite large. And then you get the diverticulitis, which is the inflammation, and that can penetrate through the wall. That can be serious and can also be very painful. A lot of people don't know that they have diverticulosis until it's diagnosed, but they do know if they have diverticulitis because of the pain that's associated with it. Again, it can be treated surgically if need be. They can go in and operate on that section of the colon, and they can resect the colon. You have a lot of colon, so they can pull the ends together. Typically, over a period of time, it will grow out again. If you didn't know that, you can lose a foot of colon because they took out the diverticulitis area, and it generally grows back in terms of length. This is not the same as polyps. Polyps go the other way. These diverticula are pockets bulging into the muscularis. If you had a polyp, a dysplasia polyp or a cancer polyp, it would grow into the lumen. And there are all kinds of urban stories. That is, should a patient who has diverticulosis eat popcorn? Well, I don't know, because they had people that had diverticulosis eat lots of popcorn, and some of them had no problem, and some did have complications. And what can happen is the development of an anal fistula, which is a hole literally from the bowel to the outside around the anus, where it constantly leaks fluid. It leaks little bits of digestive fluid and maybe fecal material. If there's a particular dietary irritant of some kind in the diverticulosis over a period of time, just the normal movements of a person can cause fluid to leak and cause an extension through the pelvic bowl. You can see this in the bottom right picture up here. A student of mine once mentioned at the rest home he used to work at, they had protocols, and they had a few people with diverticulosis and diverticulitis. And one lady couldn't have peanuts because it was an irritant to her bowel. And the interesting surgery to fix this, it's interesting because you can't go in and plug that channel. What you have to do is kind of fillet it open and let it heal again on itself. And most students ask me with this anal rectal fistula, or fistula in ano as it's called, why can't they just cut it out? If they cut it out, it would make a bigger tube, a bigger hole. Students start to realize it's like a finger growing in there, a finger hole, if you will. And they just can't cut that hole out because then it doesn't exist like a finger out pocketing. You can't take an anal fistula and put it in a bottle. An anal fistula is a hole. It's a hollow finger-like thing. It's a hole that runs all the way through. Look, in anatomy class, we used to have a bottle of dental caries. And there's nothing in the bottle. Is it empty or is it full? Because what are dental caries? Dental caries are lack of toothedness. So it doesn't exist on its own, right? You can't have a bottle of cavities, dental cavities. An anal fistula is a tube. You can't have a bottle of tubes. All the time it's going, once it breaks through to the outside, then it doesn't have the bottom of the pelvic bowl anymore. And when you see this, especially males, they're wearing Kotex pads. So a male wearing a pad is a hint that there's an anorectal fistula that has occurred. Now, you can actually Google anorectal fistula and search for images. Some people have actually put pictures, and you can see a hole right next to the external orifice of the anus where small amounts of fluid can drip through. Now, I didn't want to put an actual picture because I thought that was a little too much, but down here in the bottom right picture, you're seeing anorectal ulcers leading to a fistula, where literally those little out pockets ultimately end up at the surface of the body, and that's where you can have the intestinal fluid leaking out. Now I'd like to move on to celiac disease, also known as non-tropical sprue. What disease? It says on your study guide, what disease is caused by a T-cell response to alpha-gliadin? Well, it's glutenin, the protein, and gliadin, a glycoprotein, which are the constituents of gluten, which is a protein that's found in wheat, and some people have an allergic reaction to it. In fact, they're finding people with more and more of this, and it's called, like I said, celiac disease or non-tropical sprue. The people have an immune response to wheat, and they're finding that this is not as common as people thought, not as uncommon as people thought, because a lot of people have an irritable GI tract, And some have had it their whole life, and they really don't know any different, right? These people think the low-volume diarrhea that's associated with the celiac disease is all a normal part of living because most people don't go around talking about their bowel movements and habits. So people can be sort of isolated with the thought that what's happening to them is fairly normal, especially if it's mild. A lot of people that have low-volume diarrhea don't realize that they have an irritable bowel or they have a sprue condition. It's an allergic response, and it's easy treatment once it's identified. The easiest way to treat it is just remove wheat from their diet. Sometimes we remove that wheat, then all the symptoms go away. It's an amazing response. Sometimes with sprue, the people get psoriasis. Again, it's an immune response that's creating the dermatitis. It's a hypersensitivity condition. The dermatitis condition produces little bumps on the skin. The original diagnosis for them might be dermatitis, and especially if they're allergic to plants. A lot of people are allergic to, get this, especially ferns. I just thought this was interesting. It's quite common, especially in the garden, and if you cut the fern and you get a little oil that's emitted, the oil will cause a dermatitis. Well, they found primarily in Western Europe and from immigrants from Western Europe that typically if you have a patient with celiac disease or sprue, their heritage is probably going to be Western European, and people with celiac disease that are from Western Europe, they share a common hypersensitivity to plants as well. Now, my little picture up here, this little cartoon is showing you gliadin, the glycol protein from gluten, the wheat, which is found in wheat. You're seeing that it's entering the body and it's activating a helper T cell. It's being presented to the helper T cell with an antigen-presenting cell, say a tissue macrophage, and the helper T cell is activating plasma cells and also T cells. And now these are starting to fight the enterocytes. Lost my place here. The simple columnar intestinal cells that have gliadin antigen expressed on their surface membranes. And what happens is the T cells and B cells actually destroy the microvilli of the gut. And this decreases the amount of surface area for absorption of nutrients, and therefore the person ends up with diarrhea. Now I'd like to talk about the colon and types of polyps, because we talked about pseudopolyps with the ulcerative colitis. Now I want to talk about true polyps in the colon. There are two types. One is a polyp that looks like a mushroom or a little toadstool in a sense. And I'm showing you this peduncular polyp here in the top right picture. There's another one of it in the bottom left picture that says large colon polyp. So these are the mushroom type polyps that I'm speaking of, the peduncular. They are typically outgrowths that look like little mushrooms. If it becomes cancerous or dysplasia, typically it's on the top of the polyp where the cancer will form. And in order for this to be serious, the cancer has to grow down into the stalk of the polyp and then down into the mucosa and down into the blood vessels, and then you can have metastases. That usually takes a long time for that kind of colon cancer. That's typically the one they'll go in and just snip it out during colonoscopy, and they're fairly easy to see with a colonoscopy. They're big enough, easy to see. But the other kind of polyp is a sessile type, and it's more flat. Sessile polyp, it aligns right on the mucosa, and I'm showing you a picture of that in the top right picture, and it says sessile polyp, but also the bottom right picture is a real picture from a colonoscopy. So sessile polyps are right on the border of the mucosa, and it's a particularly dangerous kind because of the proximity it has to blood vessels. And if the cancer forms on this kind of tumor, you have more of a direct route to the blood vessel for metastasis to occur. And that's also a difficult one to see, because if you talk to someone who does colonoscopies, the polyp, the mushroom one, is easy to see. The sessile one is more difficult, and sometimes you don't see it. And that's why it's important that whoever is doing the colonoscopy is watching very carefully. Not just the camera going in, but the camera coming out. When it's going in, the camera will pass right over the sessile polyp, and they're really hard to see because they're pressed down. And drawing the camera out, however, when they're going backwards, there's a backflow of fluid, a suction as you draw the camera out, because the camera has displaced the fluid when it was going in. So as you move the camera back out, the fluid returns, and that creates a little eddy current, and that eddy current can lift part of the sessile polyp, and that's when they can see it. They can take a film when they do that, and a radiologist can examine it. The problem with the sessile is it's flat and metastasizes fairly easily, and it can be very serious. The mushroom-type polyps, the peduncular, if you see them during the colonoscopy, they clamp the end of the stalk, and they can actually take that right out while they're in there. They can remove it because the cancer is generally in the upper part of that polyp. Typically, the peduncular type doesn't grow back. But a sessile is different because if you remove or scrape it, you might not get it all because it's not as clean as getting one of those peduncular polyps. The second thing is, because it's so dangerous, they'll take a sample, and if it's dysplasia or cancerous, generally they're going to take that section of the colon out. Now, side note, I just want you to know that it was the sessile colon polyp type that got Dr. Rich McCullough, the person who used to teach this pathophys class. And it did metastasize very, very quickly. And once it metastasized, it went to his liver, and he became very jaundice, and he died so suddenly. It was very sad. Moving on, let's talk about appendicitis. People who are more prone to have appendicitis are usually between 5 and 30 years old, although the peak incidence is about 10 to 12 years. It begins as a dull, steady pain in the periumbilical area, and I'm going to tell you about McBurney's point. What is McBurney's point? If you draw a line from the crest of the ilium to the umbilicus, and then go halfway between the two, as shown in this top right picture, that's McBurney's point. If you have pain in the lower right quadrant and you press in on McBurney's point, when you compress, that's not a problem with someone who has appendicitis. It doesn't make them in pain. But when you withdraw your hand from McBurney's point, then your patient will climb the wall. And then there's a good chance that it's appendicitis. What is the purpose of the appendix? It does contain bacteria, and these bacteria do produce vitamin K. And remember, vitamin K is used for clotting factors. The appendix is not as important in humans as it is in other animals. Remember, like horses, where all their bacteria making vitamin K is in the appendix. So you can't just go in there and remove it for a horse. For us, the bacteria that make vitamin K are more spread out throughout the intestine. So removing someone's appendix is not going to create a problem with clotting. We can get appendicitis when there is an obstruction with a fecal lift. That means a hardened piece of stool gets lodged in the appendix and there's twisting of the colon. The pain is very abrupt and it's very intense, and when the pain suddenly stops, it's highly suggestive that the appendix has ruptured, and that can lead to peritonitis. Back when I was a little girl, I was visiting my great aunt in Iowa, and she had this beautiful, large old farmhouse dining room table. You know, now they sell them in Pottery Barn for $1 gazillion, but she had an original one, a huge table, and it would sit at least 20 people. And I remember asking why it was so big. And, yeah, we had a huge family, but she made it known to me that back in the old days, having a big dining room table wasn't just for the big families to eat at. It also served as a surgical table. When the country doctor would come if they needed to perform surgery, that's where they did it, right there in the middle of the living room. And I then learned that one of my great-great-great-uncles had appendicitis, and it had ruptured before the country doctor could get there to him, and he died literally on the table that I was eating my dinner on. Anyway, so I put on here a little cartoon picture showing you some classic signs and symptoms of appendicitis. And just so you know, this little cartoon guy is not smoking. That's a thermometer in his mouth, showing you a low-grade temperature. And what's the point of the basketball rebounding off of his knee? It's to remind you about the rebound pain at McBurney's point. Again, it's the removal of the hand. When you push on that area, when you push down, they don't have a problem. It actually alleviates the pain. It's when you remove your hand that the pain is very excruciating. Now I'd like to talk to you excuse me, about intestinal obstructions, and there are different types. Borginnis, I love that name, is related to strangulated intussusception. Let me talk about that some more. The word Borginnis means bowel sounds, gas in the bowel. It's a Greek term. It's a growing, growling noise, and you hear this with bowel obstructions. It's a rumbling sound. Sometimes it's a sound that you hear if you think of bowel obstructions. There are different ways of obstructing a bowel. One is through adhesions, especially from previous surgical procedures. Sometimes the bowel can wrap around and strangulate itself and blood flow is cut off. But if you do a colonoscopy, you don't usually see anything because it's a strangulation from the outside, not from the inside. There is this narrowing, and eventually that wrapping becomes so tight that it literally strangles the bowel. There is a moment when that happens because the patient up until that time has had occasional pain and weird bowel sounds, the Borginnis, but once the obstruction gets really bad and the lack of blood flow to that portion of the bowel causes it to become so hypoxic and necrotic that they start to lose the tissue, it becomes extremely painful. And they remember where they were the time the wrap made a full strangulation. If you look on the bottom right picture where it says the letter B, you're seeing the twisting motion of the intestines. The intestines can twist, or we can even pretend that this is the greater omentum wrapping around and around. And again, if you were doing a colonoscopy, you wouldn't necessarily see anything. It's the outside twisting of the intestines. And if it hasn't completely strangled and it's still open, you might not pick it up right away because your tube with the camera on the end can go through that partial little opening and you wouldn't know any different. Oh, and students also say, wouldn't you be able to see that because the volume of the intestine would get smaller if you're going through the constricted area? Well, volumes and sizes of the intestines change anyway, especially when you're going through sphincters. You could view it with an MRI because fluid builds up behind the obstruction, so you would get this dark spot on the MRI and then a clear spot below it because there's no fluid there because of the obstructions. And then students ask, well, what could cause it? Well, nobody really knows. You can just have intestines wrapping around each other. The surgery to correct it can take about 20 minutes, especially if you're talking about the greater omentum being the cause. They just open you up, go in and slice off the omentum that's around the intestines and take out the omentum that strangulated the area. Pull it back a few inches so it won't roll back, and then you just close them back up again, and it'll probably never occur again. But the pain that they experience when it becomes a complete strangulation is intense. It's indescribable. Now, what about the intussusception? That's basically a telescoping of the bowel, and I'm showing you a picture of a real one up here in the top right picture. If you want to see the cartoon drawing, it's the one labeled A. And basically part of the bowel it's part of the bowel that is pushed into another part of the bowel, and it's creating part of the obstruction. And the reason for that is there's strangulation at the end of that region of the bowel that's going into the other part of the bowel. It's sort of like a toothpaste tube in my mind. It forces pressure on the part of the colon that's going into the lumen. So the pressure will build up and it keeps pushing part of that intestine into the lumen further and further up, and then it will basically cause strangulation. Alright, it's now time to talk about jaundice, and I have this slide as a review for you. Let's start in the top left picture. The gray cell that's labeled as a macrophage, and I'll remind you that macrophages can ingest many, many old and damaged red blood cells, and they're going to recycle some of the parts of the hemoglobin molecule. The parts that can be recycled are iron and the individual amino acids that are part of the globin chains. The iron, of course, is going to be transported in the circulation by a molecule called transferrin, and it can be delivered to the bone marrow to be used to make new hemoglobin and new red blood cells. The amino acids can also be transported in the blood, and delivered to any cells, really, to be used in any type of protein synthesis. The problem is the porphyrin ring, the part of the heme molecule that was made in the mitochondria. The porphyrin ring, that's what heme is. When you take heme, it's the porphyrin ring and iron. So when you take out the iron, you just have the porphyrin ring. It's quickly converted to biliverdin inside the macrophage, and then bilirubin. Biliverdin, verde means green. It's got a green tinge to it before it's converted to bilirubin, which is more of a yellow color. That bilirubin then circulates in the blood, and we call it free bilirubin, and it will ultimately get to the liver, and the liver hepatocyte cells will conjugate it with glucouronic acid, and now we call this conjugated bilirubin. And it can be secreted through the bile duct and eventually get to the small intestine. In the small intestine, the bilirubin is converted to urobilinogen and stercobilinogens. The urobilinogen is far more water-soluble and can be absorbed back into the circulation. The urobilinogens can then be filtered by the kidneys. So it is the urobilinogens that cause your urine to be yellow. And it's the stercobilinogens that gets eliminated in your feces that causes your fecal material to have the brown appearance. To do it again, I just want to show you here that we have a senescent red blood cell. It gets engulfed by the macrophage, and the globin chains are recycled for individual amino acids, as you can see here. The heme will be broken apart into the iron, which can be released into the bloodstream and transported as transferrin, and then stored in cells as ferritin, or the unhealthy way to store iron in excess is hemosiderin. But the porphyrin ring will be released from the macrophage. Like I said, it's going to be converted to free bilirubin, and then in the middle of the screen you're seeing that free bilirubin. It's not very water friendly, it's not very water soluble, and needs to be bound to albumin for transport. Once it gets to the hepatocyte in the liver, it takes that free bilirubin and will add glucouronic acid, and now we call that conjugated bilirubin. And that conjugated bilirubin can be released to the bile, and as I said, can be converted to urobilinogens and stercobilinogens and excreted in the feces and urine. Jaundice can be either prehepatic, intrahepatic, or posthepatic. Prehepatic is usually a problem with free bilirubin levels rising, and we see this with hemolytic disease of the newborn, or sometimes called jaundice of the newborn. We also see this prehepatic jaundice when someone is given a bad blood transfusion and there is rapid hemolysis. So with prehepatic jaundice, think of it this way. The liver is being overwhelmed by overactive macrophages rapidly engaging in hemolysis of the red blood cells. So the hepatocytes are not able to conjugate the free bilirubin as quickly. With intrahepatic jaundice, this is now destruction of the hepatocytes, and we can see this with hepatitis and cirrhosis. Posthepatic jaundice, another way of saying that, is obstructive jaundice. This means a clogged bile duct. It can also be because of portal hypertension, where literally the blood pressure within the liver causes the bilirubin to accumulate in the bile duct and in the gallbladder. So the rate of bilirubin formation is normal, but it cannot pass from the blood to the intestines, and most of the bilirubin is of the conjugated type. When that happens because of an obstructive jaundice, a person's feces will be clay-colored, and you could see the urine in this person is very, very orange, reflecting that the bilirubin, the conjugated type, is being absorbed back into the bloodstream and being filtered by the kidney. Now I just want to talk to you a little bit more about jaundice and the intrahepatic pathway and portal hypertension. Okay, with prehepatic jaundice, it's typically young children, newborns of course, but also could be from a blood transfusion. But if that's the case, the blood transfusion leading to the jaundice, that would all be seen in the hospital setting. But if you see an adult coming into your hospital room and they look jaundiced, first thing you think about is some kind of liver damage, and it could be liver cancer. It could be cirrhosis, but typically when a patient walks into your hospital and they look jaundiced, most of us, the first thing we think of is the alcoholic. Yeah, maybe you think this because, maybe they're the chronic alcoholic. That would be your first guess because it's just so common, very, very common. But let's not forget that it could also be hepatitis. It could be a number of conditions. It could still be post-hepatic jaundice. It could be the bile duct itself. Because remember, the bile will actually back up and be stored in the gallbladder. And the gallbladder isn't just for storage of bile. It actually pulls the water out of the bile and is constantly concentrating the bile. Otherwise, the bile would be too dilute and you'd be having to put it down in the intestines all the time just to get rid of it. But the gallbladder is really fantastic at extracting extra water and concentrating the bile. So in addition to a bile duct obstruction, we could also have a cystic duct damage. Remember, that's the duct that leads to the gallbladder. Maybe it's leaking or anything. Maybe the hormone cholecystokinin isn't being released appropriately. Lots of things. But sadly, the cirrhosis condition is very common, and with the cirrhosis, the scar tissue, what happens is you can actually get a buildup of pressure in the hepatic portal system, in the venous system. And to remind you, with the hepatic portal system, you have blood coming up from the intestines, from the gastric vein, the gastric coronary veins. You have blood coming from the pancreas, the splenic, all the blood draining from the intestines, the abdominal contents. They're all coming up together to create the hepatic portal vein. I shouldn't say the abdominal contents, the abdominal veins. And this goes through the liver because it is taking all the nutrients that have just been absorbed from the intestines and the stomach, and it needs to be filtered or detoxed by the liver. Right? It has to be filtered. Then the portal vein comes into the liver, and the blood will go through the hepatic sinusoids. These are large veins with slow-moving blood, so the hepatocytes and macrophages that are there have time to cleanse the blood. And then the blood will go to the inferior vena cava through the hepatic vein. So all the blood that's coming out of the intestines, like I said, the gastric, pancreas, the intestines, the spleen, that blood has to go to the liver before the blood can go back to the inferior vena cava and back to the heart. With portal hypertension, it's the portal vein. The pressure exceeds about above 12 millimeters of mercury. The hypertension that started in the liver because of the cirrhosis, the scar tissue, this can happen in the alcoholic. The portal hypertension, what happens is, just to say it slower, we have cirrhosis of the liver. The scar tissue builds up, the pressure in the liver builds up, and you can actually have blood damming up through the hepatic portal vein. And when that blood dams up, it will go all the way back to the capillary beds surrounding the intestines and the spleen and the stomach. And we get increased capillary hydrostatic pressure. And what happens is this increased capillary hydrostatic pressure means that we have more leaking of the blood plasma into the peritoneal cavity, and we call that ascites. So again, the hepatic portal system, shown up in the top right picture, shows you how the small intestine absorbs products of the digestion. All of these nutrient molecules need to travel from the intestines and the stomach, etc., back to the hepatic portal vein, and the liver removes the toxins from that blood, and then the blood can enter the general circulation through the hepatic vein to the inferior vena cava. Now on the bottom right side of the picture, you're seeing a liver with cirrhosis and all these nodules, the scar tissue that's growing. And the scar tissue can put pressure on the hepatic portal vein, so you get damming of the blood, and this will lead to the ascites. And not only will it lead to ascites, but it will lead to jaundice, as the cirrhosis is destroying the hepatocytes, and you're losing the ability for the glucouronic acid to be conjugated to the bilirubin, and this means that we're going to have a buildup of unconjugated bilirubin in this patient, because it's not being conjugated. And it's not as easily removed from the body, and this is going to lead to jaundice. I'd like to quickly talk about some issues with the gallbladder. I've already addressed how we can have bile accumulating in the gallbladder, but we also can have colitis. Anytime you see that suffix lith, it means stones. So lithiasis is a stone, and when we say cholelithiasis, we mean gallstones. Cholecystitis is the condition of an infectious gallbladder, and it's usually secondary to obstruction of the gallbladder outlet or the cystic duct. So 85 to 90% obstruction of the gallbladder outlet is from cholelithiasis or gallstones. Now, what's the treatment for cholelithiasis? For one thing, surgery. You can take the gallbladder out. But you've also seen where a patient can sit in these tanks of water and they can turn on radio waves and they vibrate the gallstones, and the gallstones fall apart because they're basically just bile salts and cholesterol. You can get the right frequency, and instead of having to go in and do surgery, they can basically go in and use these sonic means to shake the stones and they fall apart. It's a good way of treating it. Now, cholestasis is any condition in which the flow of bile from the liver is slow or blocked. Flow of bile from the liver or even gallbladder. Cholestasis can occur because of a lack of hormone called cholecystokinin or CCK. Cholecystokinin is a hormone from the small intestine that targets the gallbladder to contract and have a spasm to release the bile. If you're not responding to that hormone, you have cholestasis. If you have cholestasis, where the bile is trapped in the gallbladder because it can't be ejected, then those bile salts and cholesterol can start forming the gallstones, the cholelithiasis. And that can then lead to a secondary infection of the gallbladder called cholecystitis. Now, last slide I want to talk about is the exocrine pancreatic failure. If the pancreas fails to secrete any of its digestive enzymes, again, it's the acinar cells that are responsible for making and releasing the bicarbonate buffer, mucus, and all the digestive enzymes like procarboxypeptidase, chymotrypsinogen, and trypsinogen, DNases, RNases, and pancreatic amylase. So the pancreas, its exocrine function is to release bicarbonate buffer mucus to neutralize the stomach acids, but it also makes and releases all types of enzymes to handle lipid digestion, which is lipase, carbohydrate digestion, which is pancreatic amylase, protein digestion, and that's the three enzymes that the pancreas makes that I told you about, procarboxypeptidase, chymotrypsinogen, and trypsinogen. The pancreas also makes DNases and RNases to digest any nucleic acids that you've ingested. I mean, if you eat an apple, apple cells have DNA too. You could basically break down all of these macromolecules and use the monomers for your own DNA synthesis or carbohydrate synthesis, etc. With pancreatitis, it's inflammation of the pancreas, and most of the time the autodigestion theory can explain the condition. What is the autodigestion theory? Well, the enzymes whose job it is to digest proteins, obviously, an acinar cell, the most abundant cell in the pancreas, is filled with proteins. And the last thing it wants to do is make enzymes whose job it is to digest proteins and have those enzymes be active. So the acinar cells will make these digestive enzymes as zymogens. And that means they're synthesized in an inactive form. And once they're released through the pancreatic duct, then they become activated. So traditionally, once trypsinogen is released into the pancreatic duct and into the small intestine, the pH is just so that it will become activated by a very important enzyme in the intestine. This enzyme that's in the small intestine is called enterokinase. So not until the pancreatic enzymes reach the small intestine will they be activated. And again, enterokinase activates trypsinogen into trypsin, and then trypsin can activate procarboxypeptidase into carboxypeptidase, and chymotrypsinogen into chymotrypsin. And then protein digestion can occur. With chronic pancreatitis, this means a repeated inflammatory response on the pancreas. And what happens is the trypsin becomes aberrantly activated, and this leads to digestion of the pancreas from itself. Its own enzymes are digesting it. It's very, very painful. So chronic pancreatitis is typically caused by an inflammatory response to alcohol, excessive alcohol. Acute pancreatitis is typically caused by gallstones, the colitis that I was telling you about. I'll remind you, the pancreatic duct actually joins up with the bile duct, and gallstones can include both of them because they will lodge the outlet where these two tubes combine together in what's called the hepatopancreatic ampulla. Your textbook has a picture of this. Your textbook has a picture of this on page 974, where you can see the bile duct and the pancreatic duct merging to form the hepatopancreatic ampulla. A gallstone can actually get lodged there and dam everything up in the pancreas, and that means trypsinogen. It really has a nasty autocatalytic feature to it. Trypsinogen can self-activate, and this will lead to autodigestion in the pancreas. Without the pancreatic enzyme, that means the person won't be able to chemically digest the food and cannot absorb macromolecules across the intestinal lining. We can only absorb monomers. We don't have the protein machinery to absorb full strands of DNA, for example. So if you can't digest these macromolecules, then you can't absorb them. And that means if you're not moving these solutes, then you're not moving water either, and the person will have diarrhea. If you can't digest fat, it's going to come out as fatty diarrhea called steatorrhea. And also, so will the protein and the carbohydrates as well. It's particularly nasty. With acute pancreatitis, it's dangerous because it's quick onset, and with a quick onset, you can lose that pancreas. You can lose it within a matter of a few days. When a person goes into the hospital for pancreatitis, they're going to be treated with antibiotics, and they're going to be giving that patient fluids as well because of the diarrhea. You might even need to give the patient a pancreas transplant if you can get it to them in time. Now, this is different than when we're going to see pancreatitis, when the problem is pancreatic cancer. Pancreatic cancer is one of the most dangerous cancers, and it's because by the time the cancer is detected, about a third of the pancreas is gone. So even prior to detection, it's painless up to that point, and they've already lost a lot of it. By the time it becomes symptomatic, they've lost already a large part of the pancreas. A huge difference between pancreatitis and pancreatitis caused by cancer, the pancreatitis that's acute and chronic from alcohol or gallstones, it's very painful, right away painful. The person will know where they were. Pancreatic cancer usually occurs in the head of the pancreas, and like I said, it's painless at first, and that cancer of the head of the pancreas can actually block the bile duct, and so they might even present with jaundice. That's another difference in the symptoms of pancreatitis versus pancreatic cancer. With pancreatic cancer, usually once it's diagnosed and the pain starts to set in, the pain is usually when they're in a supine position, and they'll feel it in their back and right shoulder. So that's another difference between acute and chronic pancreatitis from alcohol or gallstones versus pancreatic cancer. All right, that was a quick and dirty overview of disorders of the GI tract. I tried to keep it short and sweet because, well, this past week you were working on your exams, so I didn't want to feel like you had a lot to catch up with. Next week we're going to discuss endocrine dysfunction of the pancreas. So that obviously is a discussion on different types of diabetes mellitus. Okay, take care.